didn't work, rather than situating comparisons with medicine as the norm. So in the last 20 years, research has actually moved in the direction Joan indicated, and we now, as this symposium has demonstrated, have moved on from comparison studies to those that examine the regulatory issues that impose unnecessary barriers for patients to access the services of nurse practitioners and other health professionals. And as my co-author Dan Gilman and I have written, regulatory barriers imposed on many professions can be anti-competitive without any compelling public interest. Competition tendencies are illuminated in scope of practice regulations. On one hand, regulations are designed to protect the public by setting education, certification, and accreditation standards that assure the public that a provider has a basic level of knowledge and skills. But as we have heard today, this is not always the case. When scope of practice regulations are used by a profession to protect their market share, instead of or in addition to protection of the public, either through political alliances with legislatures or as a foundation for challenged changes in other professions' scope, they restrict other professions from providing a full range of services. And this is particularly dangerous when there's no evidence that the services provided by these practitioners harm the public or provide benefits that offset potential costs. This anti-competitive stance, which restricts services beyond the purpose of patient protection, can be used to control who can engage the public as providers at particular times and places. And many of the speakers have spoken to this, be it through regulatory definitions of providers that shape payment mechanisms, institutional privileges, or regulatory channels.